Hello, everyone. Welcome to Endoscopy Talks. I'm Dave Tweed from Colorado State University, and I'd like to thank all of you for joining us on behalf of Colorado State University and the Translational Medicine Institute. I want to introduce our speaker for today, Dr. Brad Case. He's an associate professor of small animal surgery at the University of Florida College of Veterinary Medicine. He's an ACVS founding fellow in minimally invasive surgery and also past president of the Veterinary Endoscopy Society. Much of his clinical research is in minimally invasive surgery and hepatic vascular disease. Today, Dr. Case is going to talk about endoscopic management of vascular ring anomalies. And with that, it's my pleasure to introduce Dr. Brad Case.
Hello, thank you very much for the wonderful introduction. I'm very honored to be here, and it's especially great for me, being as I trained at CSU years ago with Dr. Tweed, and I know Dr. Shamus very well, and so I was very honored to be invited to do this talk today, and I'm very grateful that all of you have attended, and hopefully we'll get to some useful and helpful information and have some good discussion. So like I said, I trained at CSU, and I love this picture right here. This was probably 2008 maybe, and this was actually one of the very first more advanced endoscopic cases that I was a part of. And this is, of course, me here on the left with my Texas A&M hat where I did my internship. And then Dr. Monet, obviously, over on the right. And so I credit him for introducing me and getting me excited in the wonderful world of endoscopic surgery. And so this is kind of where it all started. I also enjoy the student half asleep in the middle of the background here, which I don't understand how she could have been asleep during this case, because this was actually a vascular ring dissection case. And so appropriate for the talk today. So again, I'd like to thank Carl Storrs, Dave Tweed, Dr. Monet, Dr. Tweed, Dr. Shamus for inviting me, and we'll get moving. The structure of the talk that I have today is outlined here. We'll spend a few slides going through some of the background, some of the basic embryology, specifically looking at the different variations in vascular anatomy that we may come across. And then we'll sort of go through the clinical presentation briefly, but we'll use a patient that I had. It was actually the patient that we that I just showed you the picture from, that we're going to use as our model. And I'm going to use him because I took tons of pictures of that dog throughout the time of the procedure and also throughout the follow-up as sort of our model. And then we'll get into some videos and some cases that are mine that are more recent. And I'll kind of go through my approach and my thoughts, recommendations about managing these cases, the surgical approach, the different variations, how we can approach them individually, and we'll spend most of our time there. And I've got a couple of really nice videos that we can kind of play through and pause and point some things out in hopes that it's enlightening for most of you and that it leads to some nice discussion. And then at the end, we'll go through the more, kind of start with the more simple, predictable PRA case, and we'll go to maybe some more complicated vascular cases and move on from there. So, just for review, and I know there's probably a number of residents out there right now, this is classic boards question material, so I would know this much more in depth than we're going to talk about it, but at least as in depth as we're going to talk about it here. And so, as a fetus is developing, there are paired aortas, a dorsal and a ventral aorta, and they have a series of arches. And those arches and paired aortas sort of surround the respiratory and upper GI tract. Okay, and then as they're developing, many of those arches sort of involute. They lose their function and they go away. For example, the first, second, and fifth are the ones that go away absolutely normally when the fetus is fully developed. The third, fourth, and sixth hang around. We may lose one side, hopefully. We may keep the wrong side in some cases, which we'll talk about. But the third, fourth, and sixth arches are the ones that go on to develop the heart, the aorta, the pulmonary artery, the carotids, et cetera, okay? So any error that happens along that pathway for whatever reason, and we end up getting an arch on the wrong side, can lead to big problems. Okay, and so this image right here that we've got is, you're gonna find it in your surgery textbook. If you kind of look at the top, where the A is kind of canceled out, my cursor's not showing here, you can see the very early paired aortic arches and the aortas. And then as you kind of move kind of to the right and then down to the bottom, you get kind of this ventral dorsal view as these arches start to involute until you get this, what would be a normal appearance of an aortic arch, heart, and esophagus and trachea down in the bottom left. Okay. Now, if things go wrong, we can see a whole variety of abnormal, malformations and developmental issues, and the dog is going to be potentially sick from that. Okay. So again, as you go down here and you kind of go from A to B to C on the left over to D to E to F to G on the right, you see a whole variety of abnormal morphologies. I'm going to try and pull my cursor up here if I can find this. So bear with me for 1 second. Let's see. Mouse. All right, let's try this. Okay. Can we, oops. Oh, we can see the mouse now. Okay, so here is A, this is normal, all right? And as we go down here, we see what would be arguably the most common abnormality, where we have a persistent right aortic arch. So no longer is our aortic arch on the left, but it forms on the right. And we end up with our ligamentum arteriosum creating a constriction around the esophagus and the trachea, but that's usually clinically silent, okay? And then we can see other even more complicated abnormalities, like a double aortic arch here. So we've got, a left aortic arch and then on the other side, the right. So you keep two ascending aortas. One of them usually is atretic and sort of diminutive or small compared to the other. And then we can see things like a normal aortic arch, but a right ductus arteriosum, which ends up causing constriction on the right side. These are unique because we typically have to approach these from the right. I've never seen one of these cases myself, but they are reported. And then there's a whole variety of other ones. We have incomplete rings here, where again, we've got an arch on the left, so a normal arch, no ligamentum arteriosum, but we have an aberrant right subclavian, which would be an incomplete ring, and may or may not cause clinically apparent abnormalities, but can cause some entrapment of the esophagus. And then the one that I find most interesting, because I see quite a lot of these, and I think we probably have been under recognizing them, which we'll talk about, but this is going to be our persistent right aortic arch with our left ligamentum and an aberrant left subclavian. And both of these pathologies can be clinically significant. And so this is one of the things that I've been more interested in with endoscopy, how to sort of address those cases. So that's just kind of a quick run through the types of abnormalities that we see. Again, these are going to be the two. If you look in the literature, it's reported, and this reference is always, it's up in pretty much every new publication on the topic, but that 95% of these dogs have a persistent right aortic arch and a left ligamentum, and that is the pathology. Less commonly reported is the persistent right aortic arch with an aberrant left subclavian. And again, I see quite a lot of these on the human side. This is one of the most common abnormalities that, at least as far as vascular ring goes, that are seen and treated. And again, I think we under-recognize them, probably because we're not performing CT angiography in many of these cases. And it can be difficult to see that vessel if you're just making a very focal approach over the ligamentum, even if you are in there with a scope. So we'll talk a little bit more about that. So how do these guys present? We're all pretty comfortable with this. There are a number of breeds that we know it to be heritable in. German Shepherds, Irish Setters, Boston Terriers have all been reported. And then there's specific lines. Maybe not these breeds, but we saw it in a parent, and then we saw it in an offspring, or we saw it in a next generation offspring when we had seen it prior. So we do know that's congenital. There's a heritable component. So that's important to realize. Probably should be neutering these animals. Definitely should be neutering these animals. They're going to present typically with dysphagia and regurgitation, although sometimes you can see some upper respiratory signs, cough. I have yet to see one that's dyspneic, but that's maybe more common in humans with Comeral's diverticulum, which I've never seen a case of that. They may have aspiration pneumonia or something too. That's not uncommon. So that may be the cause of a cough, but it's rarely tracheal constriction, at least in my experience in the literature. And these signs typically become evident at post-weaning, so 6 to 8 weeks of age. Now all of a sudden, they're unable to keep more solid type of food down because they have this big constriction preventing movement of food down into the stomach. They're typically underweight and malnourished. One of the interesting things that I can usually palpate on exam is sort of a dilated, malleable caudal cervical region. And sometimes if you start palpating and squeezing kind of right back here on the neck, you'll get them to regurgitate. And so that's an interesting thing that you can see sometimes. And then of course, on auscultation, you might pick up crackles or something if they do have aspiration pneumonia. Most of these guys are stable, at least cardiovascularly when I see them. And so that's a nice thing for us. But they do tend to be in pretty poor body condition because they're in such negative energy balance, and they've been getting, not able to pass food into the stomach, obviously. And then this, being very, very small and sort of immune incompetent, that can present some problems for us as far as timing of surgery. And so it's been recommended to put feeding devices in, or orogastric feeding, which I have had a number of breeders do that, and it seems to be tolerated pretty well. I generally try to get them to at least 12 weeks of age. Once they're 12 weeks of age, that seems to be okay. I've never intervened in one much earlier than that. And of course, we're going to want to get some imaging and rule out aspiration pneumonia before we put them under anesthesia to take them to surgery. So try to get them in as good of body condition as possible. Make sure they don't have aspiration pneumonia. I like them to be at least 12 weeks of age. And that seems to be a pretty nice, way to go. They're not metabolic juggernauts. There's nothing super technical with the medical management of things. This is, a really nice surgical anatomic type of condition. And so there's not too much interesting, at least in my opinion there. Survey radiographs are obviously an initial diagnostic step we're going to want to do. The classic findings, at least for the persistent right aortic arch with left ligamentum, are this sort of on the DV view, this leftward deviation of the trachea, which you can see on the blue arrow here. Okay, you can also see a dilated cervical esophagus with a bunch of gas in it. And then this, on the lateral view, you see sort of a ventral deviation of the trachea. So it's reported in this study by Buchanan et al. In 2004 that if you see this leftward deviation of the trachea at the cranial heart base, that this is 100% consistent with a persistent right aortic arch. Okay, so obviously we can't see, concomitant abnormal vascular diseases like an aberrant left subclavian, but just for survey radiographs, that's pretty useful. Also, we can obviously rule out aspiration pneumonia. Contrast radiography, I don't see much use to this, although I still will get, when cases get referred, I'll still get some images when they're 8 weeks that somebody did an upper GI contrast study. I'd be careful with that. Again, they are at risk for aspirating, and so definitely don't use any of our kind of ionic barium type contrast, because we wouldn't obviously want them to get any type of that into their lungs. That can be very problematic. But even more than that, I don't typically see this as a necessary diagnostic, but it can be done. And obviously, it's going to highlight the dilated esophagus. One thing I found interesting as I was preparing for this talk a bit is this sort of 3D echo and then this post-imaging acquisition software that's available for humans. And so they're able to capture these beautiful images by 3D echo, and then obviously some complicated, post processing software. And so they can create these amazing models, at 21 weeks of age or 23 weeks of age for the fetus, just by transabdominal ultrasonography. And so they can diagnose these very early, and then that's, they can follow them. And then that helps them to sort of plan surgery, the timing of surgery, how to approach the surgery and stuff. I looked it up. A 21 to 23 week old fetus, human fetus, is around 8 inches long. So that's kind of similar to maybe a newborn puppy. And so maybe there's some use for this at some point in the future, probably not, pre-birth, but, maybe something interesting to look at. I do, like I alluded to earlier, I like to have a CT scan of these cases. I like CT scans of most things, especially when vascular pathology is involved. And again, if you look in the literature, this has been performed in very, very few cases, even in the more recent publications. So the nice thing about CT is that we can generate these amazing 3D reconstructions, and we can see very clearly when we've got aberrant vasculature, like an aberrant left subclavian here. or persistent right aortic arch is very visible and stuff. So this is really, really nice. Okay, it doesn't really image the soft tissues too well with the 3D recons, but when you put out all three of your planes, your frontal, your transverse, and your sagittal, you can very much see where the constriction is in the standard view. So you can get an idea about where the ligamentum is. Is the ligamentum patent, which we know it is in around 5% of these cases. So I find this to be very useful. And again, I think this is one of the reasons that maybe we miss some of these aberrant left subclavians, because they don't always originate right where the ductus is. Many times they'll originate a bit further down, and they may or may not actually be causing any kind of constriction, which I think is important for us to think about before we just start deciding to or not intervene with them. So again, here's our model spot. One of the other diagnostics that's very useful, and I typically do these intra-op or immediately pre-op in the OR esophagoscopy. And one of the nice things here is it's non-invasive. You just run the scope down here, and I know that the internists are very highly trained, and it's more challenging than I'm probably going to make it seem. But it seems like you just park the scope right in there, and you can see your aortic arch on the wrong side. In this case, we're going to see a pulsing aorta on the right, which obviously gives us diagnosis for at least a persistent right aortic arch. Then we'll see this very classic sort of semicircular band constriction here that's preventing passing of the scope sometimes through, or food obviously, and then a dilated esophagus. So the goals of therapy are pretty simple. We want to remove the obstruction, and so that's majority of the time going to include removing the ligamentum arteriosum, all right, plus or minus an aberrant vessel like potentially an atretic double aorta or aberrant left subclavian. And then the ultimate goal is to improve esophageal function. There are a couple things that we should think about. One is, does the timing of surgery affect this? Because I've seen cases that are 8 weeks old. I've seen cases that are 2 years old and taken them to surgery. And that's also been reported doing late term ligamentum division. And those dogs still can improve and do well and regain at least improved or significantly improved esophageal function. Okay, so that's our goal. So at this time, it doesn't seem like delaying. I generally don't like to delay things too long, right? Because I think, as scar tissue sets in and, with time, we might, at least our window of opportunity may decline to some degree. So, but I also don't like to intervene too early, like we talked about. Another thing is that the canine esophagus is striated. So, even after we've removed the obstruction and maybe they're not doing as well, they're still having upper GI signs, we're kind of limited with, pharmacology because of that, lack of smooth muscle in the canine esophagus. So many of our prokinetics like 5-HT agonists and, muscarinic receptor drugs like metoclopramide, cisapride and stuff are probably not going to be that useful. I do put them on antacids. I'm not sure how important that is because, again, I've seen quite a few of these endoscopically now, and rarely do they have any esophageal ulceration or anything. Again, the obstruction is up above the lower esophageal pseudosphincter, so we tend not to see a lot of reflux from the stomach. So I still do that. I'm not sure how critical it is. Maybe Dr. Tweet can chime in on that. The surgical anatomy can be challenging. It can be intimidating for those of you who haven't seen many of these, especially when you start working with the scope until you get some comfort with it. And you still always have to be very, very careful. It's challenging for a couple of reasons. One, these are big vascular structures, and so an error is very unforgiving in a small animal with a massive bleed. There's a good chance you may not be able to recover from that. We're always ready to convert, and we're always ready with blood transfusions, et cetera. Luckily, that's very, very uncommon to have to do that, but we're all prepared for that, and you want to know the anatomy very, very well. The other thing is that, these diagrams or illustrations look very, very nice, but that's not how things look when you're in surgery. We've got, all sorts of other tissue that opacifies our visualization and makes the dissection challenge. So we're almost, using what we know of the anatomy based on our training, based on our preoperative imaging, based on what we can kind of see in there, and sort of using that as a roadmap, even though we can't really see very accurately a ligamentum, et cetera. And so we'll go through that a little bit more. Thoracotomy is obviously how the traditional standard approach for these cases, and it is a tried and true technique or approach to accurately and effectively and safely treat these patients. So I have no reservations about converting, and I'll show you a couple of cases that I converted on as we get through to the talk. But remember, the nice thing about it is it gives us plenty of field to work in, a surgical field. We can take advantage of three-dimensional visualization, which we lose with our endoscope to some degree. We can use traditional instrumentation, which we're all trained to use and is a little bit more intuitive sometimes than endoscopic instrumentation. And one thing that's huge is just being able to take your finger and just push and palpate around and see what you feel. And we lose that with endoscopy. We can take advantage of some of our instrumentation to sort of indirectly get that, but it is more limited. There are a variety of publications, not a ton, but I kind of didn't want to go through all that because we can all go pull those up whenever we want, but probably the one that gets referenced most and is probably the one with the most cases, at least as far as traditional approach through thoracotomy, is this case by this series by Dr. Muldoon from 1997. And there was 25 dogs all approached by thoracotomy. The vast majority were PRA with left ligamentum. And they had very good results, good to excellent results in all the dogs that survived. The perioperative mortality was less than 6%. But they did have, they didn't have normal esophageal function afterwards, despite the fact that the client observed outcome was good or better in most cases. Okay, so, one thing we'll also talk about is following up on these cases and sort of imaging and trying to interpret how they're doing clinically and maybe changing the diet, et cetera. But don't be surprised, for those of you who haven't seen many of these cases, if you still see a little mildly dilated, cranial esophagus, or maybe they regurgitate a couple times a month, or maybe they can't move to dry food. That's not uncommon. That's still a good outcome. Of course, on the human side, they've been ahead of us in some ways. And one of those ways is approaching their pediatric patients with minimally invasive and specialized minimally invasive equipment. So in '93 was the first modification of the traditional 5mm instrumentation to the pediatric 2.7 size, which is useful in a number of these cases. I use it in my really small dogs. I'll use the 5mm in the bigger dogs. Both are fine. But if you can imagine, and it's worth taking note. We're beyond the days where we have to show, okay, minimally invasive surgery causes less pain, less trauma. We all accept that. Maybe there's some naysayers out there, but they're wrong. And most of our clients, when they come in, they're going to be looking at their puppy in many cases like a human child. It is their children. We all know that. That's how they look at them. And I have a child, and I can just imagine the horror that I would feel if I knew that I would have to put him through in his first year or so of life a massive procedure like a thoracotomy. Okay, so this is an image over here from that publication by Kern and Rogers, and you can see very faintly a couple of the little port site scars. So these are from that 3mm instrumentation, very small scars there. And so really nice thing to do for a human child in their first year of life, or a puppy in its first year of life. Okay. And so this study is really nice. There's a bunch of them, but it basically compared open to VATS approach for vascular ring anomaly. Most of these are persistent right aortic arch with an aberrant left subclavian. They don't address the subclavian in most cases because it doesn't contribute to pathology in most cases. Okay? It's more exceptional that they need to. So typically it's just ligamentum division, which you can see in the image down here. Here they're using Hem-o-lox. They've got a sort of suture kind of elevating the ligamentum off of the esophagus so that they can get nice clean dissection and accurately divide it. But what they found is that operative time is reduced with minimally invasive procedure. Probably it has to do with the time it takes to make a thoracotomy approach and then close the thoracotomy approach. It's much quicker to actually put a few 3mm instruments in and then close those port sites. Okay, and so that's where they save operative time. Complications are less, bleeding is less. Chylothorax post-op significantly less. Remember, the thoracic duct and branches are right around there, so it's not uncommon for those to be hit, and it's up to 40% in some of these studies. But then the huge thing is hospitalization. They're taking their child home the next day after surgery, a day and a half after surgery, versus waiting 5 days. And there's, it's no mystery why they're there 5 days, because they're in pain and they're not able to be managed without being in the hospital. So that's huge for a whole variety of reasons. And of course, those things sort of, they apply to us similarly, I would argue. And then as far as efficacy, they're saying complete symptom relief with both open or VATS, and around 70% of cases, that's no different. So that's kind of the story. Here's some of the pediatric instrumentation that you're going to want to have available to you, especially if you're going to be working in these very small pediatric patients. Small breed Boston Terrier that's 12 weeks old is not big. Okay, it's going to be really hard to get a 5mm cannula in some cases in the intercostal space. So we want to have these modified 2.73mm instrumentation pediatric set. This is a 30-degree scope. Okay, you definitely want a 30-degree scope, whether you're using the 5 or the 3mm. You're definitely going to want to have a bipolar device. Okay, and so it doesn't have to be a ligature. It can be an end seal. It can be a harmonic scalpel. It can be whatever. I do like the ligature. I do like this dolphin tip, especially for the really small guys. I have used other devices too, but this is nice because it's blunt. And it has this little taper, so it's nice to sort of bluntly dissect and very accurately divide your tissues. And then, of course, a series of instruments, a blunt probe here, a Metzenbaum scissor, a DeBakey style 3mm grasper, and then this sort of semi-right angle forceps right here. Those are kind of the workhorse instruments. You don't need much else for these cases. I'll bring this study up here because this was, again, this was the first report of a persistent right aortic arch and left ligamentum being treated by thoracoscopy, and this was by Dr. McVale and Dr. Monet. It was published back in 2001, so they were way ahead of things and sort of kind of paved the way here. Some really cool things about this study, like they used syringe casing for their cannulas, which I thought was really interesting, and they used like hemoclips here to ligate the ligamentum. This was pre-ligature, so hemoclips are probably less important to have than a bipolar device. Okay, and then just, we'll touch on a couple of papers here, and then we'll get to the cool stuff. We'll take a break, and then we'll get to the really cool stuff. Again, Dr. Monet and Dr. Nucci put this study out. This is comparison similar to the human one I just referenced, looking at dogs that have gone, these dogs all had persistent right aortic arch and left ligamentum, no other abnormal vasculature. And about half of them underwent thoracotomy, and then the other half underwent endoscopy. And 5 of those endoscopic ones were converted. So they ended up having 15 that sort of had, or 20 in the thoracotomy ultimately group, and then 10 in the thoracoscopy group. And they found very similar results. Duration of surgery, not different between groups. Postoperative complications, not different. Duration of thoracostomy tube, not different. But the big difference they found was difference in hospitalization. So the thoracoscopy group dogs were going home earlier than the open approach dogs. So presumably that's because they were more comfortable at the time of discharge. Okay, so we do have some good evidence. And then more recently, there was, or before that, in 2016, there was a study of multi-institutional study of 9 dogs by Dr. Townsend. This was from Guelph, I think UC Davis and UPenn. And these cases were a bit more complicated. 5 of these dogs actually had an aberrant left subclavian, okay? And they did have a couple that were CT'd in here. So again, I think CT angiography probably helps to pick those up. And in these cases, they did actually try to divide the aberrant left subclavian 1, but there was hemorrhage post-op, which necessitated re-intervention, okay? And so that's a documented case where we hadn't had any sort of successful initial divisions of aberrant left subclavian artery and persistent right aortic arch left ligamentum procedures, okay? But they showed, again, efficacy in maybe some of these more complicated vascular cases like the PRAA left ligamentum aberrant left subclavian cases, right? And one of the things they emphasized in here was the usefulness of esophagoscopy. And I'll illustrate that in some of the videos that I have here in a moment about how that's actually very useful, especially when you're starting out, to just give yourself a little bit of comfort where you are, and then also to kind of do a pre and post assessment. Okay, so I'll pause there and we'll see if we have any questions.
Yeah, we just have a couple of quick questions. And one was, what about in cats? Do you see cats with vascular rings, and would that be also done with thoracoscopy?
Yeah, I've seen 2 that I've taken to surgery in the last 9 years. So I don't know if that's because of where I practice, and we tend not to see, we do see cats. We just don't see a huge number. We see predominantly small breed dogs. I have done them with the Vitom scope. So I've done them sort of what I call through a kind of a conservative thoracotomy. It's just a thoracotomy that I don't crank the ribs wide open with a rib retractor. They've been very small. It is reported. It can be done, but I've not done it personally. So sorry, I don't have much more to add there.
Okay. There's one about a case that had a big, huge dilated esophagus that was very thin cranial to the vascular ring. Any tricks in dealing with those at all?
Everyone I've seen, I have that same impression that it's very thin and very dilated. So I have a lot of, well, I have some, I'll make that a focal point of the discussion as we're watching the videos, but it's absolutely critical because they are super thin. And I'm always amazed watching the flexible scope go through there when I'm in the chest, and it just almost looks like the scope's gonna pop out of the esophagus. So luckily it's thick striated muscle. I think that probably saves some of these dogs, but we do have to be exceptionally careful about how we do the dissection, whether it's open or through thoracoscopy. And I'll elaborate more on that when we play the videos to be more useful.
Yeah, there's one more question, but I think you're probably gonna cover that. And that was on one lung ventilation, if that is done on all these procedures.
Yeah, that's actually been reported specifically with persistent right aortic arch. And I've always am ready to do that. I've got my endobronchial blockers. I've got a great anesthesia team that as long as I prep them, they can jump in for that. But I have not needed to do that. I've only done 6 minimally invasive vascular ring cases now. We don't see it. I see maybe 1 a year, maybe, or maybe I go a year without seeing any. So I haven't seen a million of them. I've seen more than that I've done open, but as far as endoscopically 6. So I haven't done a million of them yet. But I haven't needed it. And part of the reason why is because of the way that I keep the instruments organized. And I can kind of elaborate a little bit on that. But basically my grasper, my assistant instrument, I keep in my left hand and it's in my ventral port. And that sort of comes up from ventral to dorsal at an angle, and it keeps that left cranial lung lobe retracted ventrally and laterally. So it sort of acts as a retractor. So I have not ever felt like I needed it, but it is reported and can be used.
Okay, that's it for now.
Okay. Okay, so just to kind of jump into the procedure and how I like to get them set up. So we usually put them, again, this is for persistent right aortic arch, left ligamentum. We're going to put them in right lateral recumbency, just like we would for a thoracotomy. And we want to kind of keep the spine elevated a little bit, maybe 15 degrees off the table. That's going to help the lungs to sort of fall down laterally and ventrally. If you've got a float table, a hydraulic float table, that's great because you can just hydraulically tilt the table. And so I'll do that sometimes instead of propping the spine up a little bit. But you can just use a rolled towel if you don't have that, no big deal. And then I like to sort of have an idea about, okay, where's the 4th, 5th intercostal space? That's where my target is. And then that helps me to sort of look at the length of my instruments, because I generally want to have half of the instrument length from the entry point into the chest to the target area, and then the other half outside. That allows me to have nice, motion and create that kind of 45-degree triangulation that we're trying to shoot for. If you have your cannula sites too close, you don't have any availability to work. You can't change the depth of your instrument. You're coming straight down maybe on your site, and maybe you want to come more at a less acute angle. So that's sort of important to get an idea for. So a nice wide clip. This is this is from the SALT textbook. I generally keep my operating table over here, and I keep my monitors over here, and I leave this space for anesthesia and flexible endoscopy. And because I don't like to have anything behind me, because I'm definitely going to have my assistant standing here, and I'm going to be working from right here. There's more than one way to do this, but that's generally how I'll do it. Like I said, this is spot on the table here. This is the cannula orientation. So you see there's 4 cannulas here. I rarely need, I've never actually had to use 4. I use 3 in just about every case. I like to have the scope up in the top cannula because that allows my assistant, the one driving the scope, to be over here and sort of stay out of my way. And then I like to put my ligature here, and then maybe in the more ventral cannula, my grasper. So you can just get rid of it. When I do it, I don't need this one here. You just get rid of that instrument. That's sort of how I have it organized. So this is going to be what I would call a good, once you've developed the skills and you're comfortable, you've got the instrumentation, you've got all of those requisite endoscopic skills, this is a good case to start with. It's a persistent right aortic arch with a left ligamentum. I'll just let the CT play, but basically you can see the aortic arch on the right, you see the area of constriction, and we don't see any aberrant vasculature. So I really like, again, to do a CT. This is going caudal to cranial, gas-filled esophagus. We can see our arch on the right side, okay? Nothing coming off of the aorta, so we don't have any aberrant vessels, no double aorta, et cetera. So this is, again, my setup here. We've got sort of a hydraulic table. These are these little grounding pads that are really nice. They're very big. They're radiolucent. They allow your water heater, your water blanket to circulate through so they get warm. So I really like these. They keep the patient very warm. These are really, really small patients and they're going to get cold, probably less so than with an open chest, but still it's nice to keep them warm. And again, this table tilts so I don't have the spine elevated too much here. Here's another view. Kind of at the end of the table, it gives us room to work. This is kind of what it looks like in the OR here. So keep anesthesia up here, keep the instrument table back here. I keep my monitor or monitors over here, and then and flexible endoscopy towards the back here. All right. So that gives us plenty of work. My assistant's going to be driving the camera here, and then I'm going to be operating from here. So there's the port arrangement. Like I said, the telescope's going to be coming in. This is dorsal up here, cranial up here. So the telescope's coming in cranial. This is 5mm instrumentation. This was a bigger dog with a right aortic arch. And then again, we're going to be using either our probe or our bipolar device through the central cannula, and then our assistant grasper through the ventral cannula. Oops. So when you get in there, you're going to see, it's sort of hard to, there's our awesome medicine group, they're helping us. This is what they see when we've got our scope on in the chest. You can see some of our instruments, and this is them in this dilated esophagus with an aortic pulse over here on the right. So I usually ask them to come in now. This just confirms. And it's nice because they can drive the scope right up to the area of constriction, and then we can see that within the chest, right? So that's really useful, especially when you're starting out, just kind of confirms that you're in the right place and that diagnosis is correct. But this is what you're gonna see most of the time. It's sort of tough. This vessel here, I don't know what this vessel is. It's insignificant. It's a little mediastinal pleural vein. Go ahead and ligate that. It's gonna be generally sitting right in your way. So I'll typically divide that with my bipolar device. Other thing you'll see is you'll see this dilated esophagus here. Watch out for nerves. You can see your phrenic nerves, usually vagus nerves. Sometimes you can see big lymphatics, so try to avoid those. If you can, oops, keep doing that. I apologize for that. So yeah, we'll divide that vessel. And then I just sort of go very bluntly. And like you were saying earlier, Dr. Tweed, the esophagus is very thin right here, and it's distended. All right, you can see it's sort of distended a bit here caudally, then it's at the level of the constriction here, and then distended here. So I don't know how thin that is, but I imagine it's less than 1 millimeter or so, or 1 millimeter or 2. Okay, so we don't want to do anything sharp until we've undermined and isolated the ligamentum carefully, and on both sides, caudal and cranial. So you can see here we're starting to use those right angle or those curved Kelly type forceps to sort of create that blunt window underneath the ligamentum. Okay, so we're starting to get a window developed here caudally. We want to make sure that we see the tips cranial as well, because if you just take your ligature and you go in there and grab, those ligature tips are fairly big. This is the Maryland tip here. So if I just put that whole thing in there, I might push or grab some of that cranial esophagus, and then when I fry it and then deploy the cutting blade, I'll cut right into it, okay? So that can definitely happen, okay? If you're careful, it should not happen. So here's what we're doing. We're going to lift the ligamentum up, continue to undermine very carefully, and you can use your Kellys, you can use your right angles, you can use your blunt tip bipolar device instrument, that's fine. But the ultimate goal is to get around to the other side so that we can see those tips to make sure that we've got the esophagus freed up on either side. On the human side, they'll use suspension sutures, traction sutures a bit, like you saw in that image earlier. But that's the goal. Okay, so nice and slow, steady as she goes. And then eventually you get to the other side, and then we can start to come through. And then you'll see at this point, it's pretty simple. I don't have it in here, but sometimes I'll use endo peanuts, those little gauze tip sticks, and we'll be able to separate the remaining fibers. Sometimes you can just sort of use a blunt probe and maybe the DeBakey, which you see right here, and just sort of gently, bluntly sort of strip them away, but make sure that there's, you know, no constriction. The esophagus is still, it's going to be much less dilated. It's not going to be gas filled with stent, but it's still going to be dilated. It's not going to immediately come back down to normal size. So don't be, you know, too worried if you see that. You know, hopefully that's going to improve over time during the healing process. I like to make sure that I've got the ligamentum completely freed away and that I get at least enough clearing of some of that mediastinal tissue that I can see normal esophagus, just to make sure there's nothing else there. We're going to drive the scope back in. Hopefully medicine tells us everything looks really good and that constriction is no longer there. They can still see some evidence of narrowing there again, because the esophagus aboral is, or ORAD is still a little bit distended and abnormal. Okay, but the scope usually passes through really, really easily. Then they can run down and look at the distal esophagus and stomach if you want. And just kind of confirm that everything looks good. Some people drag, you know, balloon catheters through there, or big orogastric tubes past those. You can do that if you want. I haven't really found there to be much need for that, as long as you can see that you've cleared off the ligamentum and all the remaining fiber spans. And then of course, we'll put a myeloid chest drain in. This is just so that we can sample the pleural space. There's rarely, if ever, anything fun going on in the chest afterwards. So I don't put a large bore chest tube in these guys, just something that they're going to be comfortable with, that I can sample it if I need to. And then I usually get that out pretty quickly. This is what it looks like after you've, in this bottom right, this is what it looks like after you've freed up the ligamentum and the fibrous adhesion. In recovery, it's pretty typical. They're pretty up and at 'em after about 4 or 5 hours. Vitals are pretty unremarkable. Their pain scores are, you know, low. It's, you know, not to date ever seen one, you know, significantly uncomfortable in the immediate post-operative period. Like I said, the chest tubes are pretty boring, so I usually get those out after 5 or 6 hours. Like I said, they're standing, their appetite returns immediately, and these guys are usually ravenous, so be careful. Don't, you know, just start letting them eat all of a sudden. We still want to stick to small volumes, elevated slurry feedings for some time period until we allow that esophagus to heal up as much as it can, all right? So don't just let them start chowing away on dry kibble and stuff. Activity restrictions, probably not super critical. I usually tell them 5-7 days, keep them quiet, monitor the surgical sites. You know, once those port sites are healed up after, you know, 7 days or so, there's really, you know, we're not worried about hernias or anything. That's just not going to happen. Elevated feedings, I continue at least for 6 weeks, if not longer. And it sort of depends on how they're doing. I will, like I said, keep them on antacid. I use famotidine. Again, I'm not entirely sure that that's needed or not. It's just what I've done. I explained my thought behind that. I'll send home tramadol for a couple days if they need it, but again, most of the time the owners aren't going to be using that. If you look at their pain scores, they're usually close to preoperative. And then I usually plan to get thoracic films at 6 weeks, and then again, sometimes maybe 4 to 6 months, and you'll see the esophagus improve in that time period. So this is, you know, again, this is a case that that Dr. Monet did. It's the, you know, that case that we've used as the model. And you can see here at 6 weeks, his recheck, he's much bigger. He's in better body condition. I'll generally have them continue elevated feedings to this point. And then, you know, depending on how they're doing, start to maybe move to, you know, maybe a wet gruel, not elevated, small volume, see how they do. Keep them quiet for, you know, 20, 30 minutes afterwards, just so they're, you know, you don't want them to eat a bunch of gruel and then run around and then have it all come right back up. So I'll generally do that. And then I'll have them do that for a while. If that's going well, then we can start to try and do soaked kibble. And if they do soaked kibble well, and then I'll usually just keep them there if that's cool with the owners. Sometimes they don't. Sometimes we got to, you know, keep them on a gruel diet to minimize any kind of regurgitation and food coming back up. But I'd say that's the exception, at least with the persistent right aortic arches and left ligamentum. Radiographs at 6 months are recommended. And again, by this time, you've probably get all the healing you're going to get. You might still see a little bit of gas. You can see it in the radiograph here, the lateral, some gas distension in the cranial esophagus, but the vast majority are doing well at this point. So we've got 5 minutes. We can stop for a question or two, and then I can go for another 5-10 minutes if you want. I've got some cool stuff.
Yeah, we just have a couple of quick questions, and I would like to encourage anybody else to send in questions that they may have. And one was a question, what were those, on your case, what were those sort of gray cannulas? What kind of cannulas were those that you were using?
Yeah, those are thoracoports. They're a disposable 5mm cannula made by Medtronic. And I just took they come with a little rubber valve on the outside. You can just peel that rubber valve off. I love those cannulas because, you know, it's by definition a single-use device, but it's hard, robust plastic. I've used the same ones 50 times probably. So they're really nice. They're smooth. They don't have a trocar tip on them. So I like them because I feel that they lessen the risk of lacerating an intercostal vessel or something. And remember, these are small dogs with really tight intercostal spaces. So if you try and take a 5.5 Turnamian tip through there in a really small dog, you might lacerate that vessel. So that's why I like those.
Okay. Are there any tricks in trying to get rid of some of the fibrous bands on some of these cases?
Yeah, I mean, I've had a couple of open cases that were older dogs, and I actually had an older dog that I did that's in this little series we're working on, and I have seen them be a little bit more mature, and so a little bit more challenging to deal with. And one of the videos I have is dealing with it with Spencer tenotomy scissors in an open case. But in all the cases I've done endoscopically, I haven't seen those more mature, thick ones, and so they usually strip away pretty easily. And I like the endo peanuts. Those are, again, those little sticks. They look like a blunt probe, but they have a kind of a gauze tip on them. And those are nice just to sort of bluntly sort of strip it off. So
likely the earlier you do it, the less fibrosis you may have.
I think you could say that, at least in theory. I can't tell you that from experience, again, because I haven't seen millions of these yet, but I think that makes sense.
Okay, well, that's it for now. So.
Okay, well, I'll keep going because we got some other interesting stuff. So this was a case, we'll get into some challenging cases. So this was a case that I saw a while ago, and it was a rescue dog, and we had to kind of get money together to deal with it. We had some survey radiographs. The dog was in pretty good condition. It had what we thought was consistent with the persistent right aortic arch and left ligamentum, and 95% odds. We don't need a CT, let's just go for it. So we went into the OR, and of course we had medicine in there, and we ran the scope in there, and we did not see this. We saw an aortic arch on the left side. So that made us worried. And so I said, well, we're already here. Let's just put the scope in and look. And so that's what we ended up doing, or that's what I ended up doing. And so this is what we saw. You can still see the esophagus. It's dilated, but we've got a left arch here, which is normal. And so I thought, okay, well, this is weird. Maybe this is an aberrant right subclavian, or maybe this is a persistent right ductus, okay? And I just picked the wrong approach, but I wasn't super confident. So I dissected around a little bit just to see if maybe I could see evidence of the ductus, ventral to the aorta. Long story short, I could not. And so I said, okay, well, I'm not just I was nervous to just flip the dog over and do a thoracotomy, which probably if I had a vast more experience, maybe 10 years more under my belt, I probably would have done that. But instead I took it to CT. And when we did the CT, we'll just focus over here on the transverse. We saw that the dog had a double aorta. So if we go down here, so this is kind of the ventral aorta right here. This is the ascending aorta over here on the left. But notice here, we have an atretic right aorta. So I'll play through that. So it goes back up and then plugs back in right here, entrapping the esophagus and the airway. So it was really, really tight. I remember our internist telling us, this is weird. I can't see anything and it's really tight. So this was a double aorta. So at this point, we got our diagnosis after we looked at the CT for a while. And then I ended up doing a thoracotomy over here on the right. So this is cranial vena cava here. So double aortas, this is the only one I've ever seen. I've not seen any others, but if you do have to go after the right arch, count on the vena cava being right in your way. So I'm not entirely sure this would have ever been a case that I would have been comfortable with, doing thoracoscopically, okay? They are done on the human side thoracoscopically, but anyway, so if you come across these cases and you need to go over on the right side, I'd probably recommend doing a thoracotomy. You're going to get obviously great exposure and good outcome. The more interesting variation that I see quite a bit of, honestly, in the last 5 years, I've seen more of these than I have of just the persistent right aortic arch and left ligamentum alone, is the PRAA left ligamentum and the aberrant left subclavian. Okay, and so you can see in this image here, B, this is a dog, and this is from that paper that I've got referenced there by Menzel, a series of German pinchers, I think, that all had this anomaly where the aberrant left subclavian was originating right where the ductus is off the aorta, and it's causing significant compression and constriction. So if you would have just, it would have been very challenging to just go after the ligamentum because you'd have this big artery sitting right over it, but you probably would still have clinical signs, okay? And that's been my suspicion and my concern in a number of these cases, which we've actually gone after and divided the ligamentum, which I'll go through here in a second, okay? So this is something I think we need to be paying attention to. Again, I think CT angiography is probably a good thing to do because we're probably going to miss some of these. And again, in this paper by Townsend et al., they had one of these cases that they went in, they left the subclavian, but the dog still had persistence of signs and they had to come back and divide it later, I think a year and a half later. So there are cases, and the dog did well after that. So there are cases that we need to be dividing the subclavian. This is the case that a recent one, again, this is a PRAA left ligamentum, but also an aberrant left subclavian, which you can see there. It's going to be coming in right here, plugging in. There's the vertebral artery right there, which is important to recognize. So this one, again, it's going to look very similar when you first get in there to a PRA with left ligamentum, but there is a subclavian artery there, which I don't think I would have saw necessarily had I not done the CTA. Okay, so very similar. There's that vessel again that we're going to go through. This is the dolphin tip. I'm going to speed up a little bit here. And again, we're using the pediatric instrumentation here. So this is all the 3 millimeter stuff. Here's our pulmonary artery down here. And you can see the ligamentum a little bit there. These ones, we're going to need to dissect the esophagus, dissect the mediastinum off the esophagus more cranially so that we can find that vessel, okay? So here we're going to go in bluntly. Again, this esophagus is very thin, so tips are always up, whether you use a right angle or these kind of curved Kelly style forceps. Everything is blunt until you get that ligamentum isolated away from the esophagus. Don't just run the ligature in there or the bipolar device you use, because you are at risk for putting a hole in there. Okay, and go little by little. Okay, I know that there's an aberrant subclavian right there because I did a CTA, even though I don't see it yet. So we're going to free off that ligamentum, and still there's a little bit left of it. And as I'm going to slow this down a little bit right there. So let's see here. I didn't actually capture a great image of the vessel before I cut it, but it's right here. This is the aberrant subclavian, okay? And then this is our ligamentum. So its origin is very close. So we'll go through the ligamentum, and then we're going to end up going through the, this subclavian measured 4 millimeters, 3.5 millimeters. So I was comfortable using the ligature, but I've seen a couple bigger ones that I was not comfortable, and I'll show you what I did there. So, okay, so here you go. So you can see the end of the subclavian is right here. Here's where the ligamentum was, the edge of the ligamentum. So notice we've cleared off, dissected the esophagus open quite a bit there so that we can see, well, there's the artery that we ligated. And it's, of course, retracted dorsally and ventrally. And we can see the esophagus is nice and cleared off, and then there's where our ligamentum was. So that's how you want to, that's the exposure you're going to need if you're dealing with a subclavian artery. So this is another case. This was a bigger dog, and he had an aberrant left subclavian artery, which was causing quite a bit of constriction, but was measuring 6.5 millimeters. So it was pushing the limits of our devices. And I was obviously not comfortable using any of our bipolar devices for that. So what I did in this case, and the other thing was I was worried about tying this off because, you know, once we do that, we're pretty much relying on the vertebral artery to reverse blood flow from the right side to the left side to provide perfusion to our left forelimb, okay? And so what I wanted to do, because this thing was so big, was make sure that I had good exposure. So I did sort of what I call a mini thoracotomy. You just put the wound retractor in, so we're not spreading the ribs. This is nice because we can use our finger, we can use our traditional instrumentation, and we don't have to spread the ribs open, which I think is probably a lot of the source of pain from a traditional thoracotomy. Okay, and we keep our scope in there because now we can sort of see what we're doing. All right, and what I wanted to do was put a tourniquet on there, and we put Doppler on the left forelimb, and it is amazing when we tied this off or we tourniqueted it, the pulse pressure disappeared. It was gone for about 4 minutes, and then we could start to hear on the Doppler a pulse. Okay, so that worried me because I knew this thing was very constrictive and big, and I was worried about dividing it and then, you know, having some problem where the vertebral artery was not patent for reversal and then not being able to remove that constriction. But we ended up dissecting it off and dividing it. And then this is just vertebral artery anatomy. This is an old study on the human side. They see this, it's called subclavian steel, and basically they get atherosclerosis and arterial disease, and they get a vertebral artery obstructed. And in this case, the left artery was obstructed, or the left subclavian was obstructed. And so they weren't getting good vertebral flow. And so they did a contrast study. And if you look on the right image, you see injection into the right vertebral artery. In B, you see some opacification of the cerebral vasculature over on the left. And then you see reverse flow through that left vertebral artery, which is going back down into the subclavian and then out to the left forelimb. So that's what we're hoping happens in these dogs, and it is what happened. You can use hemoclips. This is a case that one of my colleagues, Dr. Alvarez, did, where he used hemoclips to ligate the aberrant subclavian. I've used a ligature mostly. I'm going to I think we're pretty much at the end, so we'll just stop here. So in conclusion, I think thoracoscopy is an effective, safe, assuming you have the training, the skills, the instrumentation, the experience, etc., to dissect dogs with persistent right aortic arches with left ligamentums. There are a subset of dogs which we can deal with with aberrant left subclavians. If there's any concern at all, converting to thoracotomy is the wise thing to do. Emergent conversions should be rarely, if ever, needed. Again, caution with the dissection, that's critical. You don't want to put a hole in the esophagus if you can avoid it. Although I think Dr. Monet had a case where he did some very technically advanced intracorporeal suturing to repair esophageal injury in a case recently he presented. And I think it's, again, something that's worth noting that these are desirable, it's desirable technology and approach that our clients are going to be asking for. And obviously, as we're all doing more and more of this, we're going to get better, get more experience, and hopefully continue to have good outcomes, or at least consistent outcomes with open surgery. So here's our double aortic arch dog on the beach in St. Augustine up on the left, and then here's Spot, the case that Dr. Monet did with me as a young resident that inspired me to kind of move into this profession. So thanks everybody, that's all I got. I'm happy to stick around for a bit if anyone has any questions or take questions by email.
Yeah, thanks, Brad. That was really great. I don't have any questions, so if anybody does have questions, maybe they can email you. I think it was good to see that you did need an internal medicine person every now and then to help scope, so we're not completely removed from this. But anyway, thanks so much for your presentation, and this will be available also online for anyone to view at a later date as well. Next Wednesday, we're going to hear from Dr. Clarence Rawlings. He's talking about urinary calculi and using the scope. Dr. Rawlings is one of the early leaders in laparoscopic procedures and has a lot of good tips that he's probably going to tell us about. And that will be next Wednesday, September 23rd at 2 p.m. That's New York time. And again, remember, you can watch these online presentations at endoscopytalks.com. So wishing all of you well in your practice in these trying and challenging times, and we look forward to seeing you again next week. So thank you.